for that.
Perfect. So hi again. So I'm Dr. Gyles Morrison. I'm going to be giving a talk on clinical UX. We'll give you a crash course on what it means to work in this field, the type of projects that you could work on, but also give some insights specifically into what it means to really apply UX principles, UX theory into healthcare, the impact that that can have on health outcomes. So we'll start to learn a bit about that as well. I don't mind being interrupted with some questions, and I'll try and provide some breaks within the talk so that there can be a bit of Q&A, not just have it right at the end. And I've got you until midday, I believe. Is that right?
Yes, that's right.
Oh,
Yeah.
perfect. So let's bring up some slides. I think that would be useful as well. And I'm going to bring up. And just to remind me, everyone here is a medical student past year one, right?
So, not necessarily. There's quite a variety in our
Okay.
society. There's like, computing,
Right.
different healthcare courses as well. And
Mhm.
yeah, so I think people are just putting in what they're studying.
Okay, then. This is useful to know because there's some slides. I'll expand on it a little bit just to make it a bit easier for folks to fully understand uh what I'm talking about. I want to give an example of a project I actually did when I was a student. Doing my master's degree. I'm going to add these actually to my slide deck real quick and then share. Hopefully this will add some more insights for you. Um, okay, let's share now. I think it's a bit about time now. Right, share. Always clear what goes on with this. A moment, sorry about that. There we go. I think that will work now. Has that popped up for you?
Yeah, we can see that. Thank you.
Perfect. So, clinical UX. The way to understand clinical UX, first and foremost, let's try and get a better understanding of what UX is. Does anybody at least know what UX is an abbreviation for, just to start off with? This should be an easy one. No takers? There we go, user experience. But what does that mean? User experience is about the experiences that people have with anything designed. You have an experience with the screen that you're looking at, the speakers that you would be using or headphones that you're using right now. Depending on the design of those screens, those headphones, those speakers, you'll have a better experience or not. You know, you can't change the fact that it's raining outside, but you can influence the experience that you have by putting up an umbrella and the quality of that umbrella. Like, is it a windbreaker one? Is it gonna, get inverted because of strong winds or not? Is it actually fully water resistant? Because I have actually used umbrellas that are semi-permeable, which are not fun. Again, people designed it to be that way. You design something better, you can have a better experience. Not guarantee the experience that you have, but you can influence it based on what you make as a product, as a service. In healthcare, now healthcare UX is really going to be any experiences that people have with healthcare technology and services. So this is the full gamut from there could be posters about eating 5 fruit or veg a day. There could be a mobile app to improve your health, but it's not a regulated app. It's not something that's been gone through clinical trials. It could just be a conversation that you've had with a clinician about health, even though they're not your treating physician. This is still an interaction with healthcare services. And all of this is an experience that people can have that can be good or bad and anything in between. Clinical UX is that subsect within healthcare UX. It's where there's a specific focus on the experience that clinicians and patients have on healthcare technology and services. So we'll go into some examples of this work soon. But before that, I want to talk a bit about the different types of roles a UX professional can have. So just like with medical school, you have to learn all kinds of topics. You go to nursing school, learn all kinds of topics. Once you graduate, you're still going to be a generalist, but at some point you're going to specialize. And the specialisms within UX are quite important. And you can have one person that does all of it, a bit like, yeah, you have a GP that can be good at a variety of different topics, but you can have people that primarily focus on a particular discipline as well. So broadly speaking, it starts off with being a clinical UX researcher. So a researcher is someone who's really going to be doing a variety of qualitative, quantitative research. And you really should have expertise in both. Oftentimes, you might focus primarily on qualitative research and literary reviews, but there are folks that are pretty much data scientists that are also doing UX research. And it's ultimately understanding what the hell's going on so that there's a better set of data that can be used in the design process to create a solution. Now, oftentimes, when someone says that they work in UX, they may actually be what they will call themselves a UX designer. It gets a bit confusing when some folks call themselves product designers or they will call themselves UX, UI designers. But ultimately, a UX designer is someone who takes the data and information about a problem and finds a solution to it. And 99 times out of 100, 999 times out of 1,000, that means creating a digital product. It doesn't have to just mean that because a UX designer can also be a service designer. They may also be designing services. And that's sometimes seen as a different discipline, but I push back on that because ultimately, whether you're creating a digital product or a service, you're still creating a solution. And it's the same skill set of research and design being problem solving, not the artistic side of design, where that's what's going to be of need, of demand to make a solution for people. Next, then, is a UI designer, and that is very much more on the visual design side of things and visual communication, data visualization, and that is a subsect within UX and pretty much for digital products. Then there's a UX strategist, which is what I spend most of my time doing, which is really more about looking at the oversight and the strategic planning of UX resource. So actually understanding what UX work needs to be done and making sure that the most effective path to success is pursued. Set out maybe some standards and practices. Whereas being a UX manager is overseeing that resource over time. So when there's an actual project, they're overseeing that project being successful from a UX perspective, even if they don't do the UX work themselves. So, pillars. So, I think what I like about the clinical UX pillars, these are basically principles that if you follow these and you don't have any UX expertise, you're already on path to do great UX work. So it's a bit like what can be applied to working in healthcare in general. Even if you don't have extensive medical knowledge, there's some basic principles that if you follow, you can keep someone alive or you can at least be helpful to someone. So there's five of them. I'm going to go through these in turn. So respectful, inclusive, innovative, rigorous, and ethical. So the first one about being respectful. This is ultimately about recognizing that you're dealing with human beings who deserve to be respected. We should treat them with respect. The manifestation of treating people with respect isn't just about being polite to them. It's actually showing compassion. It's actually recognizing their rights and adhering to those rights, respecting those rights, and making sure that people who are vulnerable are also protected. So this has been the case for a long time. The fact that more people have access to mobile phone than essential healthcare services. This has definitely been the case for maybe about 5, 10 years now. And it's only getting a bit worse. The other thing to keep in mind when we talk about health is that health is not just the absence of disease. It's making sure that people from a physical, mental, and social well-being are at the best place they can be. And when we introduce the social component and remind people of the mental part, which tends to be forgotten, we recognize there's so much more we could be doing for people's health than just helping them if they've had a heart attack or helping them deal with cancer. Like, these are important, but on a global level, it's still, as much as they can be the biggest killers in the world, there's still many other issues that's leading to people to have really terrible quality of life. And this is something that UX professionals can help out with. Inclusive design then is really about looking at the needs, limitations, and preferences that of patients and clinicians, to be fair, whilst considering diversity. I'm really recognizing that people are going to have a variety of needs and wants and limitations, and this is going to be unique to them. But if you're providing a solution that's for the general public, it can feel a bit daunting. And what does it mean to help everybody? And we'll come to that in a bit about serving the underserved. But in the basic principle is make sure that you're not just trying to serve one person, you're trying to serve as many people as possible. So it's a move away from this idea of let's see what's going on with an individual, the end user, and actually the ecosystem and the different players within that. So if you are creating a mobile app that's given to patients to manage their health, the clinician that treats that patient should also have insight on that data because the clinician is still treating that patient. Then there's going to be staff that are non-clinical that's working with that patient and needs to be aware of it as well, potentially. And then there's even the staff that manage this technology on the supplier side, the people who made this app, they need to have a user experience to maintain it. So all these different people have to be considered, and you have to recognize that impact on serving one stakeholder could impact others. So you've got to keep that in mind from the get-go. Then there's being innovative. So really it's about the idea of continuously trying to improve what you have made and continuously improve health outcomes, gathering feedback to make sure that you've got those insights to evaluate and be clear that actually you can make something better. Now, this slide might be unique to perhaps all of you. It demonstrates a process, sometimes just called a human design process, but this one specifically is called the double diamond design process. It's an older version, the original version of the design framework from the Design Council. Now, the framework that they have, I think it can go over people's heads, so I like to keep it simple with this one. And ultimately, it's saying that you have a problem situation, you have divergent thinking, you expand the way that you're assessing the situation to gather as much insights as possible and then process that to understand it and narrow down to the specific problem. So make sure that you're solving the right problem as a result. So you then expand and casting it far and wide on all the different ideas that you could have on solving that problem. And then you narrow it down on creating the ideal solution, the right solution to the right problem. So ultimately, following the design process is about solving the right problems with the right solutions. Now, as much as this seems like a linear process, as shown with these arrows, you can go backwards and you probably should go backwards to make sure that what you're doing is actually correct. And how this differs from medicine, because it's very, very similar to medicine. How it differs is the fact that with medicine, it being evidence-based, you kind of know, generally speaking, what the outcome is going to be once you've got a diagnosis. There's less experimenting. It's more that you're doing those investigations to confirm that this treatment works. Whereas in UX, there's can be times actually you can be very confident that when you've identified the problems that's going on, that this solution will help or this feature functionality will help, but you still need to go through some testing, a bit more so than what happens in healthcare. Now, this gentleman might be familiar to you. Now, back in 1998, he made it very clear that the situation of processing health data was unacceptable in the NHS. To be blunt, it still is not acceptable. Still could be a lot better. But his quote here, if I live in Bradford and fall ill in Birmingham, I want the NHS to be able to treat me. Now, the National Programme for IT had a budget of about £2 billion in 2002, which isn't really a lot of money for the nature of the project that they were trying to do, which was to basically digitize the entire NHS. And there were some successes. There was NHS Mail, which has been successful. It has been really good, actually. There was having the N3 network, so it's super fast broadband connection. Decades before that became something for the general public to benefit from. I think the other thing as well is the summary care record has been very powerful. I remember my clinical days where it will be a Friday after 5, GPs are closed, or after 6 even, GPs are closed. And I need to know what the medication this patient's normally on. And the patient has brought their meds because it was an emergency when they came in. But the summary care record has got that data. So there's some stuff they did well, but it wasn't all sunshine and rainbows. Um, Arguably, this became the biggest national IT project disaster in UK history, maybe even the world's history. Um, and the NHS staff working on this um, had four core private suppliers, which really complicated things. And yeah, it was very damning because the budget ballooned to 6 billion, which, to be honest, again, that's probably closer to what they needed, but it was ballooning because of inefficiencies and competencies. And in the end, it was quite clear that the original vision for the national program for IT in the NHS will not be realized. Yet another example of department fundamentally underestimating the scale and complexity of a major IT-enabled change program. So this was, you know, formally investigated this failure, and the failure of it led to anywhere between 12 and 20 billion pounds being wasted, mostly wasted. Because, like I said, there were some successes. But the final cost of that range is quite damning. And part of the reason why is that range, there's many billions that was spent in court costs and paying back suppliers, still paying them even though they didn't deliver. Some terrible, terrible contracts. So yeah, feel free to Google that national program for IT. It's very, very interesting what happened. So next then, rigorous. Make informed decisions grounded in research. Like, we're all dealing with sciences, we're dealing with facts with students. It's about understanding that if you can't trust the data that you're working with, how can you make informed decisions moving forward? So this whole concept of evidence-based design, basically. And generally speaking, in healthcare, if you actually take design seriously, and when I say design, again, I'm repeating that point, it's about problem solving. And problem solving will require experiments, it will require an understanding of having data that you can trust. All of this leads to a 42% increase in revenue and 108% increase in return to shareholders. And this came from a report done in 2018, Value of Design by McKinsey. It's a good report, actually. It's still very valid to this day, even though it's 7 years old. Another thing as well, this was some research done by Lovovitz and Chang in the early 90s. And broadly speaking, it's not an exact science, but generally speaking, that for every dollar or pound that you spend preventing a problem from happening, you will spend maybe 10 times that amount correcting that problem if it happens, to try and prevent it, bringing about a correction. And then the failure, the output of that failure of that problem happening can be cost you 100 times more. And again, it's not an exact science, but generally speaking, and this is true, um, it is much cheaper, even if you spend a lot of money doing extensive research, that then speeds up the design process. So you're not designing and then figuring out things are wrong. You're designing based on the insights of what the problem is. And then whatever's built is built, and you know that what you've built as a digital product, as a physical product, or created as a service, you know is going to work, or at least it's very, very low risk of it failing. But if you have to fix the problem, then you have to still figure out and improve upon the end solution that's been released after it's released, then for sure that's going to cost you a lot more money than just interviewing some people over the phone or on MS Teams or something like that. Development resource, especially engineering and physical products manufacturing, is very, very expensive, far more expensive than just interviewing patients. So, the last area then is ethical. So, design solutions that promote fairness, justice, positive impacts on users. Do what is right. You might have heard of dark patterns. It's been rebranded as deceptive patterns because not everything that is dark is bad. So, yeah, deceptive patterns are basically any tricks used in websites and apps that make you do things that you didn't mean to, like buying or signing up for something. I'm sure we've all experienced that. You might even have experienced it today. You were on a website and you had to get rid of some pop-up that was trying to sell you something or convince you to give away your email address. Now, generally for this slide, it's just highlighting a conclusion that was drawn from reviewing a whole lot of peer-reviewed papers that there's many digital health products out on the market which has no evidence or very low quality evidence that backs up that they can say what they do is true. You know, the whole Ronsell, it does what it says in the tin type thing. A lot of these apps, they don't deliver. You know, they're promising that you use this mental health app, it will cure your depression and anxiety, and it's never had a clinical trial. It's never had input from an actual psychiatrist. Don't trust it. Flee. Don't use it. Okay, I want to give an example of what it means to apply some of this work into practice. Specifically, it was for a master's degree project, my MSc in human computer interaction with ergonomics. This is a picture of a gentleman who is going through a sickle cell pain crisis. It's a very, very, very painful condition and it can be fatal, should be treated as a medical emergency. People who suffer from a sickle cell pain crisis, also known as a vaso-occlusive crisis, are people who live with sickle cell disease or sickle cell anemia. For those who are not familiar, sickle cell disease, sickle cell anemia is a condition of the red blood cells inherited from both parents. You have to get genes from both of them. And with this condition, it turns the red cells, when they give off their oxygen as they go around the body, they go into a crescent moon shape. And as you can see in the bottom half of this picture, when it goes into a crescent moon shape, it can get stuck in the tiniest of blood vessels, which are capillaries, particularly those in bones and joints, muscles. And this causes excruciating pain when it happens extensively. Triggers for this can be the cold, can be stress, can be infection. And worse is when all three of them happen. And my wife lives with sickle cell anemia. So when she goes into a vaso-occlusive crisis, I have to treat it as a medical emergency. She's actually quite well with it most of the time, so we can manage it at home. But when it's bad, it's really bad. She has to go into hospital, get IV fluids, get very strong pain relief, morphine, and have to be investigated for infections and treat that with some broad spectrum antibiotics just to be on the safe side before results come back sometimes. Now, it's a rare condition. We're talking about 15 to 20,000 people in the UK that have it, with a population of, I think it's about 70 odd million we now have in the UK. It's quite a small percentage of people. But, we are spending at least 20 million pounds on vaso-occlusive crises across the country, which is a lot of money. And per day, you could save um, nearly £600 per child and just over £450 per adult if you can reduce that length of stay that they go into hospital with a vaso-occlusive crisis admission. How you can reduce that is ultimately by being more prompt with that treatment of pain relief, of IV fluids, and really making sure there isn't any infection. If there is, treating it appropriately. Now, if we could actually reduce one admission on average per sickle cell patient who goes in with pain crises regularly, it could save the NHS about £7 million. So about a third or so of what has already been spent per year just by reducing one admission per year, which is a lot of money to save. Now, there's been a variety of apps. None of them are available anymore. So I was like, actually, I need to find a way to, is there any way technology can help these patients? So first, I need to understand what was really going on. So one is there's a care plan on a shared drive not accessible by A&E staff. That was the first scenario I was hearing about. So there is information about what to do for these patients, but A&E staff who first see the patients don't have access to it. The next situation is that notes in the digital care plan, but can't be found by A&E staff. And then the last one is that there's no care plan at all that exists. So in all these situations, there isn't the information on what to do for these patients who have a rare condition who clinicians may not see very often. And yeah, you learn about it at medical school, but the truth is, unless you see these patients, how are you going to really remember what best to do for them? I remember I had for those who are not in med school, but we have OSCEs. These are the physical examination tests, and I failed one of the OSCEs. I think it was my third year OSCEs, and we had a renal physician consultant who was helping us deal with our different examination techniques. And one of them was to do an ear examination. And the consultant just told me straight, you don't remember how to do it. This is a consultant renal physician. Any problem that you have with the kidneys, he's supposed to have world-class knowledge on what to do, but he does not know how to examine your ear. And to be honest, why should he? How many times does he have to examine someone's ear? There's a problem where the patient has to be on dialysis. So with that in mind, it's like, of course, clinicians are not always going to know, but it is a bit more complicated than that. Um, there are other reasons why these clinicians are not giving the patients what the care that they deserve. Um, and just learning first, well, what is the issues that the patients are having? One is pain management. People are not giving them the pain relief that they need. One of the reasons for that is that the patients are often feeling stigmatized and mistrusted. There's times when really there are actually racist beliefs that people have about patients with sickle cell, because the vast majority of sickle cell patients are of African or Caribbean descent. It doesn't mean racist that they hate these people, they want them to suffer, but there could be this perception that because you're black, you might actually have a lower pain threshold than white patients. Some white clinicians and non-black patient clinicians genuinely believe this to be the truth. The other thing as well is these patients feeling that they have to convince the clinicians of the legitimacy of their pain as a result. And then there's a lot of poor quality of emergency and primary care versus planned care. So when the hematologists are involved, these patients have a great experience. But when no one really knows about sickle cell or doesn't feel confident in treating it, they won't really do what patients need or deserve. So then I was like, well, what's the different stuff that I could do? Loads of features and functionality. And ultimately, with this slide, it's like, can we have information about what should be done for the patient? Can we connect to the EHR? Can we actually have instructions on what other devices we should be putting up data from? So wearable technology. But how could I prototype this and what's the value? So I was just processing my thoughts here. Um, but the main thing here as well was recognizing that no matter what, a constant in this patient journey is the patient themselves. And even though there's all these different stuff that could be done for that patient, we got to think about what's the solution that's going to help them the most. And so I started creating some personas, just thinking about what are the main ways that the main players that are involved with all of this. So I came with a persona of, an actual patient themselves, and they can be a professional, you know, the hematologist that normally sees the patient, and then also someone who would first see the patient when they go into a pain crisis. So a receptionist, triage nurse, A&E nurse, and the actual emergency physician. And all of this then led to me thinking, what if we had a mobile app that had the patient's care plan, but on the patient's phone? So forget about it being on the hospital computers, because the hospital computers, they're hard to get access to at times. And even if you can have access to it, do you know where to find this in the patient's health record? Because again, when I spoke to some of these hematologists, it would be in a clinic letter. But the clinic letter doesn't say care plan, it says just letter. It's just under a folder called letters, which is deep within some EHRs, and it's not going to be at the foreground for some clinicians. So you're really, really investigating how you're going to find it. But the patient is going to be a constant. And even in the so-called developing world, so across Africa and the Caribbean, most people have a smartphone device, not a mobile phone. They can have their care plan downloaded to their phone. Doesn't have to have internet connection at all times. It's already downloaded. It's the most up-to-date information after they've seen the hematologist. And so it went through a few iterations, but generally speaking, it's like, what do you do in an emergency with this patient? What are you going to give as treatment immediately? And then provide a bit more insights about, well, what is sickle cell if you need some more information. So the patient can just hand their phone, just bring up the app, hand it to the clinician, say, this is what's going on. This is what my hematologist said you should do. And I tested this out with some hematologists and they gave some positive feedback about giving it some clear instructions on what to do for these patients and when to escalate. So it's recognizing that these people as patients deserve to be respected, but so do the clinicians. The clinicians don't always want to be told what to do, but clinicians love guidance. They love guidelines and that are clear and from a trusted source. So I'm respecting the autonomy of the clinician, but giving them the information that they need to make the best decisions possible. I'm also supporting the patients to get the best health outcomes that they deserve. And recognizing that there has been efforts at trying to make this work with other apps, but you've got to keep innovating. And you've got to be inclusive in the design, recognizing that some of the clinicians are going to be complete novices when it comes to sickle cell, and others who may have seen sickle cell recently but don't know what to do with this patient. So, for example, my wife lives with sickle cell anemia. She's chronically anemic. She plods along at an HB of like 73. Normal is like 130 or 11 to 100, 110 to 130, depending on the units you're using. And we were seen by A&E, sorry, emergency physicians, and then by a hematologist in the USA. And when my wife was very, very anemic, he wanted to give her 3 units of blood. In doing so, she went into supraventricular tachycardia. For those not familiar, it's a pathologically fast heart rate that can kill you. And the reason why that was dangerous is because her problem wasn't that she was very anemic. Her problem is that she was having a pain crisis and she needed to have what's called an exchange transfusion, where the same amount of blood that you're giving is what you're taking off. Very, very different concept to having a top up of blood. And it put too much strain on her heart. She's alive and well, but she could have died. Really, she could have. And it's recognizing that there's going to be specialists who are dealing with a very unique case, that unless they've got the best information from clinicians that regularly see her, such as the clinicians, the hematologists he sees in the UK, they can make poor decisions, which is what happened there. So it's really important to recognize that you've got to be inclusive with the design. Anybody with different mindsets, different experiences have to be considered in the design process and have evidence that backs up what you're doing. Like all the instructions being provided here come from nice guidance. And finally, it's having evidence that backs up what you're doing in the sense of having this tested as a final solution. So this was tested in a laboratory setting with hematologists, not as a real product. That's to come, but it still was thinking about those different 5 pillars in practice and what it means to create a solution that is really going to work and make impact. Right. I'm going to pause for a moment. Any questions? I want to talk about competencies, like the skills that you need, but I don't know if there's any questions based on what I've just said. Quick ones. Okay. So there's quite a lot of different competencies people can have when working in UX in general. They begin with these UX ones. So the whole concept of doing exploratory evaluative research to understand what's going on, creating prototypes or mock-ups of an idea, actually engaging with different stakeholders, leading to software development. And there's also storytelling, like presenting what you've learned to others. Now, in healthcare UX, it expands a lot. You're going to be interacting with healthcare professionals and patients. You have to consider what's going on with healthcare branding and marketing. You might have to consider about specific applications of law and regulation within healthcare, privacy. What does it mean to involve AI, machine learning, augmented reality, virtual reality in healthcare? And then when it comes to clinical UX, it gets even more complicated because there's very specific technologies in healthcare. So decision support tools, digital therapeutics, telehealth, clinical trials, clinical pathways, care plans, so on and so forth. So as a clinical UX professional, I need to know all this and more. Now, to break it down, I put it into these 5 categories. So psychology, design, healthcare technology, and professionalism. So if you're dealing with psychology, it's really looking at the application of science and research and understanding people. There's design, which is problem solving, which can involve creativity and artistic skill as well. Then there's healthcare, like how do you deliver healthcare services and make sure that you solve the biggest health problems, but also provide healthcare services for them for everybody. Then there's technology, understanding how healthcare is impacted by different types of technologies, software, physical devices, so on and so forth. And then professionalism. So methods, mindsets required to work effectively to apply all of this in a workplace and to actually impact people's lives. So if there's just one key skill or knowledge area for all of these, they should focus on, these are the following. So there's healthcare behavioral science, there's soft system methodology, understanding clinical pathways, digital therapeutics, and clinical UX maturity. So, healthcare behavioral science is a scientific discipline to explain and predict changes in behavior of humans and animals to encourage good or prevent ill health. That's it, basically that. Now, there's many different approaches that you can apply to understand healthcare behavioral science. The one that I find is the most useful, quite rigorous, it takes a bit of processing to make it work, is the theory of reason action. This is the one I would suggest that you Google. So basically, the theory of reason action says that a variety of beliefs that you have, beliefs of the behavior that you can have, the beliefs of that you have, that other people have, like what's the normal beliefs people have, and the control that you think you have over the behavior can all lead to whether the behavior happens or not. So, for example, what's your belief of having 5 fruit or veg a day? What's the beliefs as you understand that other people around you that you care about that are an authority in your life in some way? What's their beliefs of having 5 fruit or veg a day? And then actually, what's your belief or understanding of the control you have, the ability that you have in even having 5 fruit or veg a day? So whether you think it's a good or a bad thing is only part of the reason why people go ahead with behaviors. It's what other people think, and also whether you even have the money, the time, the resources, the access to the fruit or veg that leads to someone actually having it. And that's what this reason action approach is really good at trying to break down and make you understand. And all of this is obviously augmented by people's previous experiences, their culture, their religion. It could be just their upbringing, whatever it is. All of this is going to influence those beliefs. And new inputs can change those beliefs as well, new insights. It can even be smaller experiences that they have over time that lead them to be convinced that they can change their behavior, so on and so forth. So this is one I would recommend learning more about. Next then is soft system methodology as a means of problem solving. So generally speaking, that whole ability of taking knowledge, processing it to come to a diagnosis or recognizing and labeling the problem to then find solutions. I think if you're a student doing the studies that you're doing, that kind of makes sense to you. But what happens when it's not a clear problem that you're solving? When it's very ambiguous or there's not a clear starting point? This is what soft system methodology is for. It's used specifically to solve what we call wicked problems, problems that are ill-defined and have an unclear starting position, such as let's make the NHS paperless. You have foundation trusts and just regular hospital trusts. Foundation trusts can keep surplus money that they get from the Department of Health. Regular hospital trusts have to give back any surplus money that they have, so they can't reinvest into the hospital. It's harder for them to function. So when there's a mandate, you all have to use this software, but the NHS isn't paying for it. You have to find the money for it out of your budget. Actually, you've already shown that it's not going to be easy to say, let's just go paperless in the NHS. So the National Programme for IT and what it was trying to do was definitely a wicked problem. that was not being solved with soft system methodology. Let's have a look at of this, because again, it's out of scope to go through all the details. But this is an example of a rich picture. It's a visual representation of a kind of like a mind map type setup of loads of different understandings, the world views, the actual opinions and expectations and needs of different stakeholders within healthcare. And it's showing you there's GP clinic, local hospital, someone's home, office or work environment, study environment, and how these all interrelate in relation to someone's health. And it's when you look at it like this, you're like, okay, I see some problems happening in the GP clinic. Maybe I'll start exploring and investigating more there and see how can I bring positive change to this system that's going on here. Because the system is made up of different types of people and technology. And by bringing a change, you can disrupt what's going on in both positive and negative ways. But you've got to investigate, you've got to start somewhere. But you look at it from the rich picture and say, okay, this aspect I want to investigate some more. So it's a great way of trying to break down a complex scenario and situation into more manageable chunks to then explore the possible. And it moves us a little bit away from solving problems, but rather improving situations. Because if people think everything's working and people are actually still being treated, is it a problem? Some would argue it still is, but if people don't agree it's a problem, it's very hard for them to believe that they have any responsibility to find a solution to it. So in clinical pathways, I think the clinicians here would already understand this, but a clinical pathway is an evidence-based tool that allows you to manage what you're doing for a patient, to give them the right care, to optimize how best to treat them in a predictable clinical journey. So this is one to deal with someone who's having a stroke and deciding whether if it's a hemorrhagic stroke or if there has been ischemia, there's been a blockage of blood flow rather than a bleed, then you give different treatment and it's recognizing what to do as the next steps. Now, with regards to technology, really understand, actually going back one thing with the clinical pathways. The reason why I think it's really important to understand this is that a solution should try and fit into the current clinical pathways or improve upon them in ways that clinicians can accept. If you disrupt the workflow too much, people will reject it. So then digital therapeutics. Is any evidence-based digital technology that prevents, treats, or manages ill health? Quite simple as that. So mobile apps that deal with chronic illness, there's gone through some sort of clinical trial, it's backed up by evidence-based medicine, but a digital version of that is assessing people in a way that you can trust. That's what digital therapeutics are all about. And there's loads of solutions out there now for this. There should have been a video that plays here. Here we go. Yeah, it's playing. There we go. So this is quite an old video. It just highlights that you can have some chat bot features. It doesn't have to be complicated. You don't have to use AI. There's loads of talk about AI. You don't have to use AI to make this work. It's much easier to do it without AI, in fact. But you can get insights about what someone's HbA1c is or the glucose reading on the spot, and then decide what best to do for that patient, how to direct them. Now, the professional side now, just closing up on that now, is really looking at how are the UX principles being embedded in what's going on. And really, it's easy to see when this fails. Like a huge amount of money was spent on the track and trace app. There's conflicting views, but it's many more billions than needed to be spent. Put it that way. So, learning clinical UX. Broadly speaking, there's 5 ways that you can learn about clinical UX. And it's not that dissimilar to what you're doing with your own studies for your professional careers. There's formal study, what you're doing at uni. There's self-study, which is when you're learning more about a topic that you already have some understanding of. So with formal study, you don't know what you don't know. That's why you go to university, to learn the stuff you don't have any insight that you didn't know. When you've got that little bit of insight, like I want to learn more about this, or I know that there's a weakness here, that's the self-study part. Then there's networking. There's learning from others. There's sharing what you've learned with others as well. So being part of a community, like what you're doing here with this group. Then there's mentorship, specific people in the group or external who have been there, done it, worn the t-shirt, like me. I'm willing to come and help out and give, pass down knowledge. And it's worth keeping in mind that with mentorship, have more than one mentor. There's no one person that has all of the knowledge that you would need for every single problem that you have on earth. Like, it doesn't work that way. You need a variety of people you should be speaking to and learning from their different experiences and insights. And then put what you've learned into practice through actual experience. So again, it's seeing real patients. It's actually putting what you've applied to real scenarios, so on and so forth. This slide just highlights how each of those different teaching and learning opportunities lead to the specific skills above, but in principle, embrace all of them. And is applied to any discipline that you're trying to learn. So not just clinical UX, it's the case as public health, in medicine, in health psychology, in biotechnology. So as we close in then, some tips and tricks. Clinical UX is not work everyone can do. Most people might have the potential of being really great at this, but actually you should have people who are dedicated to it. It takes training and experience to be good at UX. We shouldn't be democratizing everything. So for example, we have physician associates that do the work of junior doctors, and that's a good thing, but they are still going to be limited in the training that they've had versus a doctor, and also that of a senior doctor. Is recognizing that we need to have that variety of people, but recognize what are they actually trained and qualified to do? What are they being supervised to do? And in UX work, it gets really complicated, and you should have people who are professionals doing it. So, life as a clinician is hard. For those who are medical students, you have some insight into that. It, when you actually work as a clinician, is when you really understand what it means. So there's a complex lack of resources makes it difficult to give consistently good care. This is the truth. This is a worldwide phenomenon. Even in some of the best hospitals in the world, they will still have problems sometimes when they don't have access to the right personnel, people, resource. Life as a patient is hard. No one fully knows what it's like to be a patient unless you are one yourself. And even then, there's going to be something about the patient's culture, maybe their religion, their sexuality, their age, their gender, that's going to impact their health in ways that you wouldn't fully understand. You may have some understanding, but you don't feel it the way that they do. Clinicians inherently understand UX. It's pretty cool actually that that whole process of diagnosing patients mirrors the whole designing process. Focus on innovation, not just inventing. Inventing means making something new that hasn't existed before. So creating the tricorder from Star Trek. This device can assess and treat patients in just a press of a button, like that doesn't exist, not even close. We should be innovating. We go from, you know, the really massive mobile phones, which was a massive device in the back of a car that had to have a satellite dish on the car as well, to something that truly was portable that could fit in your pocket, but it needed to be a big pocket or a big bag, to something that was then the size of a stick of lipstick. I know that got out of fashion after a while, and then we got these massive smartphone devices because of the big touch screens. But those were innovations built on the technology that came before it, because it's much easier to innovate than to invent, building on something that already exists. And it means that you're putting old solutions to better use today. Still to this day, stuff like text message is extremely effective. And adding credit to your phone using USSD, the hash code and bunch of numbers, that predates SMS, the most basic technology communication that we have. And people are able to pay bills with that, to send money into bank accounts using M-Pesa, which relies on that same technology. Very, very basic, very, very, very effective. Except feeling overwhelmed. Um, which I think is an understatement. Like, you're gonna feel like everything is a bit too much. Even as a doctor, definitely speaking to the medical students, but anybody working in healthcare, there's gonna be stuff that you don't fully understand. whether it's the specialty that you're dealing with at a given time or even the patient themselves. Look what happened when we had COVID. People didn't know what the hell to do. Support the greatest health needs. Really, we should be making sure that everyone is getting the healthcare that they need, and we're only as healthy as our sickest member, as a group, as a population on the globe. Try and see how we're going to help people who are suffering the most. A way of thinking about that, processing that, is about this concept of limiting users. So any legitimate user who may have a difficulty engaging or achieving a goal with a product or service. So how I like to describe this is, say like we've got this scenario of having to wash clothes. So Tim, we can say he's 14, he's got some dirty underwear he needs to wash. He can use that washing machine on his own. Now Pippa is elderly with arthritis. She struggles with the button to open the door because it's deliberately stiff to make sure that it can't be just opened easily, which we'll get into in a moment. And for Pippa, she's a limiting user. She has a legitimate need to use that washing machine to wash her clothes. It's just that it's harder for her because of her arthritis. The little Laura, now she's an abuser. She's not that she is verbally or physically abusive to people. I mean, she has improper use of the washing machine as a 3-year-old who could wash the cat. So the button has to be stiff to open the door to prevent Laura from opening the door and putting the cat in there. And then that's not, a clean cat. That's a dead cat. This is why we have to think about how we're creating solutions that we're not alienating people who deserve to use a solution. Now, a vulnerable person is any person who can't fully protect their human rights and provide for themselves, or at risk of not being able to provide for themselves. It's going to be all kinds of people: the disabled, homeless, elderly, someone who's pregnant, newborn babies, someone who's abused, asylum seekers, so on and so forth. These are all people that are vulnerable, that deserve to be healthy, and we shouldn't be forgetting about them. But the truth is that anybody could be underserved, and it's not going to be obvious. And so with this, you've got to be thinking, is there any person whose needs are not met or actively considered by a product or service, even though they're legitimately supposed to be a user of it? Um, and so it's moving away from just targeting people who are overweight and just targeting people who are very healthy. There's going to be loads of people who's in between. And this was an example of how there's times where we're not focusing on the fact that there's a diverse population. Pulse oximeters notoriously don't work very well on darker skinned people. Better ones, more modern ones do, but this has been a chronic problem. So people recognize that, there are issues that we need to accept, but this encourages you to act. As a call to action and a call to arms. Tools of the trade, Sharpie pens to work on post-it notes, figuring out ideas. And keep in mind, folks, your greatest health is your greatest wealth, sorry, is your health. Thanks for listening. And stay for more than just 2 minutes because I'm conscious of the time, but hopefully that's been insightful for you all.
That's perfect. Thank you so much. Thank you so much, Dr. Morrison. So just have one quick question for you, actually.
Sure,
Going
sure.
from clinical medicine to like working for yourself must have been quite a big change.
Yep,
So what would you say were some of the challenges that you faced and how did you overcome those?
it's a really good question. The first one, working for yourself, means that you have to be a salesperson. You cannot avoid it when you work for yourself. You have to be in the ability to communicate your value and not assume people will see that value as great. It's not that dissimilar to dating. Yeah. People on
Hmm.
Tinder, Match.com. I met my wife on Match.com. And she still tells me to this day, like, she remembers how she thought I was just talking about myself a bit too much, not really asking about her. And that whole interaction just wasn't working in the beginning. It's obviously
Yeah.
worked now. We've been married for since 2018 with 2 children. But
Okay.
it's those first interactions, like you don't have to face those when you're working as a doctor, when you have a specific job and you're in that role, you don't have to sell the value of your work normally because it's assumed by you being in that job that if you're sick, you go and see the doctor. If there's a public health outbreak, you speak to a public health professional. You've got a device that needs building, you go to a biotechnologist, bioengineer. So it's these sorts of things you have to keep in mind that selling and sharing and communicating your value becomes so much more important when you're working for yourself. I think another major thing to consider when you're working for yourself is that you don't know when the money's coming. It's very normal that you may put in terms that you get paid half of the money or some of the money up front. The rest of the money is on delivery. It's a very classical way of delivering for creative professionals, so photographers and the like, artists, musicians. But when you work as a consultant or contractor, you might be billing every month and you get paid 30 days after you've given the invoice. So you've worked for a month, you then don't get the money for another month after that. And that can lead to hardship. I can test that. I've even had a time where the company I was working for, the client, they weren't paid by their client that we were serving for 90 days. But I'm like, that's a you problem. I have to get paid based on 30-day term. That's what our contract says. But all
Mm.
these things like having legal cover is essential. And I've had to use legal cover. There was a startup I worked with that refused to pay me many thousands. But and they threatened to sue me if I was to complain. They said, "Oh, because of Brexit, EU, this nonsense." Like, no, the contract is clear. So the lawyers were back and forth with their serious terminological terms and just whatever they were doing with. I got money. So yeah, it's going to be a bit hard. You have to sell.
Mhm.
You have to recognize that contracts are really important and have legal cover. Some bits of advice to begin with.
Yeah, that's really insightful. Thank you. I think there's a question from the chat
Yeah.
as well.
Any specific courses, resources you recommend for medical students wanting to get started in clinical UX? The first thing is, particularly for medical students, but also anybody who's a student, ace your exams. Really, I cannot stress this enough. It's going to be harder to be effective at clinical UX if you already failed at one course that you were doing beforehand. So that's the first thing to keep in mind. I do teach a clinical UX course. It's on hiatus at the moment. I've done a few cohorts of that. But generally speaking, where I was saying before about those five things to learn about, learn those. Learn about behavioral science, learn about soft system methodology, learn about clinical pathways and care plans, learn about digital therapeutics, and then learn about UX maturity, not even clinical UX maturity, but just UX maturity in general. If you already do that, you're on the right path. If you know that you want to work in digital health, even though I don't recommend focusing on one technology over the other, it's worth being familiar with Figma just to get used to some of the UI design work that's done there. Um, the other thing to keep in mind is try and learn about what's happened behind the creation of apps that go to market and what is the actual true value proposition. So, not the value proposition that the startups are touting, but what are the actual end users, customers saying is the value proposition to them? Because you'll find that there's a lot of apps that go in the market. They say they do all this great work for people with type 2 diabetes, a very common one. If you speak to an actual user of the product, they're like, I downloaded the app. It looks really, really good. It's got some recipes that I can follow. It's got some tracking that I can do about my diet and my sleep and exercise. But actually, after I download it, I stopped using it for after a few weeks. And that was a year ago. Try and understand why that's happening. And it ties back to the issue of behavioral science, the wicked problem of dealing with chronic illness on such a diverse population, digital therapeutics, why it's working or not working, and what is it about the UX maturity of that organization, why there's loads of other companies that are doing good job in solving, for example, tackling people with type 2 diabetes. Why did this one fail? So try and find the root cause of the problems. But to be honest, if you're a medical student, you're going to be busy as it is. So just keep that in mind. Please ace the exams, pass at least, and have this as something that you might do on the back burner. And the other thing I would add actually, have a chat with me. If there's projects you want to work on, you've got ideas, let's have a chat. I'll see what advice I can give to you. And there'll be people in my network that can reciprocate as well. You're welcome, Marissa. Any more questions? I don't mind if people unmute if that's easier for you as well.
Okay, so um, it doesn't look like there's any more from the audience at the moment. So
But Marissa's
um,
typing something. I'm not sure
oh,
what she's.
oh, is she?
Or you could unmute Marissa.
Hi,
Hello.
thank you so much for this talk. I was
No
just
problem.
wondering, what sort of people do you usually deal with or sort of work with on a day-to-day basis the most?
That's a really good question. Patience is the least as our clinicians. Um, it depends on the project. When we're busy with the research, I would then be doing research with clinicians or patients. But even before then, I would be doing some sort of desk research. Not that it's similar that when you're a medical student or in public health and the like, you should look at the clinical record, look at the paper records to understand what's going on first before then speaking to the patient themselves. So most of the time, I'm actually dealing with other product professionals, so engineers, other UX professionals, project managers for the planning on the execution of the work. So that's why one of the skills of stakeholder management is so important because there's times you're dealing with people who they want to do great work and they are experts in their own right, but their discipline is far removed from UX work. So it's a bit like how sometimes you'll get not rivalry, but like some tension where, you as a physician or surgeon is trying to get your patient to have an investigation and you have to speak to the radiologist. And they're like, oh, I've got someone else who has to be in front. And like everyone's vying to have the next slot for the CT scanner. But the next step would be actually, oh, there's something going on with this patient and I need to get legal involved. They think very differently than the clinician or the patient would think. So it's regularly dealing with people who have conflicting views or agendas, pursuits than what I'm doing. So very commonly, I may be working with people. Their measure of success is that we've had loads of people download the app. I'm like, I don't care if people download the app if they then don't use it. I care about people getting value out of the app. That's my measure of success. And so when they're asking, oh, can you, create this feature, change this design to get loads of people to download it more? I'm like, I can do that. But if we keep driving people to download an app that's not very good, that's going to cause more problems to us. But if the person only cares about the downloads, I have to then communicate how solving my problem helps them because they don't care about my problem as much as they care about their own problem. That's just human condition. So that's why it's really important to recognize the different stakeholders that you work with. That's why I've tangented a bit off your question. That if you're a clinician yourself, you will already understand how to interact with clinicians and patients. But it's when you don't work with them, it's how do you still be in a position to do great work. And part of it is the whole like Dale Carnegie, how to win friends and influence people. Read that book. That will help for sure. Some more questions then. What advice would you give to someone who wants to do what you do? Also, what are key strengths needed to work in this field? So, as mentioned before, there's a long list of skills to have. If you're in clinical UX, those 5 areas I mentioned. I think the other thing to be clear on is whether you want to do this part-time or full-time, because you can do this alongside working as a clinician, for example. And most of the times it means that you're working in quality improvement. That's very often a term that's used to describe what is really UX work, where you're doing some sort of audit, you're then figuring out what the real problem is, and then you're putting out a solution. You can do that part time, you can do it as a secondment. I think the other thing as strengths needed to work in this field, um, remember that you're not always right, that you won't always have the right solution, that you will have failure. I think particularly those who are doing medicine, when you have your face the first death, you have your first terminally ill patient, you recognize you can't solve every problem. And when you face that, to then be in this field, it's a bit easier to accept that actually there's not a win state that you can achieve here. And really have critical thinking. Always be sure that you trust the data, the information that you're using to make decisions, and just make sure the best decisions are being made, especially if the decision is being made by someone else. That's then forcing you to do something because it might mean that you need to do something a bit differently to achieve success. So critical thinking, I think, is a really, really important skill generally, especially in this day and age of AI, which is getting people to not think so much and trust the data so much. They just blindly trust it rather. Critical thinking is important. So biotech student, I'm looking to work within the medical field of biotechnology. Would understanding and using clinical UX be beneficial as a resource in this field? Definitely. As I'm currently unsure of my direction other than wanting to lean into the medical side of biotechnology, clinical UX is ultimately about making sure that clinicians and patients have the best experience with healthcare technology and services. So anything where you're going to understand about human factors, ergonomics, so that's ultimately what is it about how someone thinks and how they are as a person? What is it that can lead them to do something that harms them? And ergonomics is what is it about someone's environment that could put them at risk of harm? Understanding both of those, which is within the remit of learning about UX, is essential. Another way of knowing about it is human computer interaction. So, how humans interact with computers and achieve goals. That involves human factors, ergonomics, behavioral science. This is, I think, should be considered mandatory knowledge for someone working in biotech because whatever you're creating as a solution, even though it's a biological in nature, how is someone going to fit this into their workflow? What is it about the expense of it or low expense of it that's going to make someone more likely or less likely to use it? Is it a radical change, the symptoms that they may feel by using this biotech, how that can influence them? And does there have to be any tracking of this patient's health over time? So is there a mobile app that needs to be used, wearable technology that needs to be used? You as someone in biotech could influence that as well. So yeah, I think clinical UX, it's not mandatory, but so much of the topics within clinical UX will be relevant if you're truly, really focusing on positively impacting the clinicians and patients with the biotech solution. Right, hopefully that's answered those questions. No problem, no problem at all. Okay, I think we might be wrapping up now then.
Yes. So, um, I guess, Dr. Morrison, thank you so much for such an insightful talk today.
No problem.
We really do appreciate you sharing your time and knowledge with us. And I guess just to everyone, as you can see, Dr. Morrison is very approachable. You can contact him on LinkedIn. We'll put the links on the group chat. So, yeah, thank you.
No problem. Enjoy the rest of your weekend, folks. And yeah, happy to connect. Do reach out if you've got any questions. And yeah, take care. Bye for now.
Thank you.